All right, so we are here. My name's Amanda Finley. I'm with COVID-19 Long Haulers Discussion Group. And Jim, introduce yourself. Tell us a little bit about your work at CIBS and Vanderbilt.
Yeah, thanks, Amanda. My name's Jim Jackson. I'm a neuropsychologist in Nashville, Tennessee. I'm a professor at Vanderbilt University Medical Center, and really for 22 years or so have been working with patients with cognitive problems due to medical issues of various kinds. For decades, that work focused on the long-term effects of critical illness. We studied and we clinically treated people who'd been in the ICU. And when the pandemic first started, we certainly started seeing COVID survivors who had been in the ICU, but then we started seeing COVID survivors with cognitive problems who had not been in the ICU, many who were never in the hospital. And I'm not sure I needed anything to add to my plate. I was doing fine in the ICU world, but it became clear that the needs of long COVID patients not in the ICU, including in the ICU, was so great. And this has really become a passion of mine, working with long COVID patients who have huge challenges, as you know, who often feel marginalized and dismissed, who often go to neurologists or psychologists and they are overlooked. They're told that they're just fine. It breaks my heart when I hear that. It's so familiar, this reprieve. And it's really my pleasure to try to advocate for and to try to help support cognitively impaired long COVID patients. So that's what I do.
And we thank you so much for that. A lot of good work has come out of Vanderbilt that has not gone unnoticed. So let's just start right in here. What kinds of tests would a long COVID clinic do for brain fog? And we can talk about brain fog itself and that term and how it sometimes is.
Yeah, sure. So let's talk about this. And I know this is one of many questions. So I think people have widely varying opinions about the term brain fog, right? Like the majority of people that we interact with don't love the term. I think some people feel like it's useful, but I think the majority feel like it is not hugely descriptive. And I think, in addition, many people feel like it's minimizing quite a bit. That is, you interact with long COVID patients who will say, I don't know about you, but this isn't just a fog that I have. It's far worse than a fog. So I think a far better term probably for the majority of patients is a brain injury. This is a lot more like a brain injury for many than for brain fog. And if the question is, how do we engage that in a long COVID clinic? The answer, I think, is very carefully. And the answer is it probably doesn't get engaged very much at the level of a long COVID clinic. Probably the most you can hope for at a long COVID clinic is a fairly simple, fairly straightforward cognitive screening, often using a test like the MoCA, the Montreal Cognitive Assessment, maybe using a clock drawing test. You draw a clock in a particular way, maybe using a test called the mini mental state exam. And excuse me, if you score in a clinical range abnormally on those tests, then often you get referred to a neuropsychologist for a proper kind of more comprehensive evaluation. And I think that the issue is not what tests are given. I think the issue is more what domains should be assessed, because there are 101 tests that people could use. But I think the answer is attention and something we call executive functioning, which has to do with planning and organizing, multitasking, aspects of memory, in particular working memory, processing speed, language. Those are the predominant domains that we want to engage. Relatively infrequently, people have memory deficits of an amnestic nature in the context of long COVID. Rarely they look like the deficits seen in Alzheimer's disease. More typically, they have a bit of what we call a dysexecutive flavor. People have problems with something called working memory, but not necessarily with delayed memory. Often the problem is more related to attention and processing speed. I'm getting in the weeds here, but the key is domains, not the tests, Amanda.
Yeah, thank you. That's a great answer. And this sort of feeds into that. What sort of results or parameters would some of these tests report? And again,
Yeah, at the rate I'm going, we'll be done at about 10 o'clock,
that's
right?
okay. We're
Yeah,
good.
yeah, okay. I'll address a broader question, again, not asked, but maybe anticipated. Often people are a little unclear, long COVID patients with cognitive problems, whether they should go to a neurologist or whether they should go to a neuropsychologist. And I think it's a fair question, but they do very different things. And neurologists have a vital role to play in so many areas of medicine. However, um, if I had to pick a specialty that long COVID patients kind of get frustrated about a lot, it probably is neurology, because often when people go see a neurologist, the neurologist is thoughtful and engaged, whatever, but very often long COVID patients don't have positive findings in the context of a standard neurologic exam. Often if they get an MRI, they get neuroimaging, maybe ordered by a neurologist. Often it is normal, or it's very nonspecific. Often the neurologic exam is normal. So that doesn't mean the patient is normal, by the way, but often that's what is found out. So probably, in my way of thinking, at least, the place to start is not so much with a neurologist if you're having cognitive problems. It probably is with a neuropsychologist. And in that interaction, what's going to happen is you're going to take a battery of tests. If it's a true neuropsychological evaluation, that battery may be 4, 5, 6 hours long, might take a whole day. And that battery of tests is going to do a couple things. It's going to reveal the severity of your problems, for one. That is how severe are they relative to what we think they should be. And it's going to reveal the nature of the problem. So how profound are the deficits, and where are they? Are they in memory? Are they in processing speed? Are they in both of those? Are they in language too? Even though you think they're in memory, could they be driven by attention? Neuropsychological evaluations will reveal all of those sorts of things. And in so doing, they will lay the groundwork for rehabilitation to target deficits in those domains. And importantly, if a neuropsychologist thinks you need a neurologist, they'll refer you to one. So I would start with the psychology and then move to the neurology.
Yeah, I actually used to type for one in New England, so I had a little bit of knowledge going into this, and yeah, that all makes sense to me. Thank you. This one, I have a lot of people asking this. Could having cognitive impairment in my medical file negatively impact me in any way?
Yeah, gosh, that's a great question. I was talking to a gentleman earlier today, and very successful guy, thoughtful. And he shared that he talks quite widely about his long COVID, except that he is very reluctant to talk about brain fog because he's worried, his term, brain fog, because he's worried that that will raise the specter of things like competency and capability among his peers. And I get that. So, so many people are concerned about this. I don't think in the medical system, this is my experience. Now, other people may disagree, but in the medical systems that I have operated in, I don't think there are necessarily adverse consequences related to having a note in your chart or even a diagnosis that would say something like cognitive impairment, NOS. You know, patient has cognitive problems secondary to COVID. Patient has a brain injury following critical illness. I don't know that that's harmful to people. Where I think people do have to be really careful, and you should be thoughtful about this, is not so much in the medical community. I think it's more related to the workspace. We've had some people who have been beautifully authentic, who have been wonderfully genuine and real, and they walk into their boss's office and they think they're doing exactly the right thing, and they take off their mask figuratively, right?
Yeah.
And they let their hair down and say, you know, I've got long COVID. I'm having some problems with my memory. I'm having some problems with my attention. And they get punished as a consequence. So I think far more than in the hospital system, where I'm not sure people are necessarily treated any differently, in the work or educational community, you have to be careful how you're going to tell your story. And you should spend some time thinking about how you want to tell your story. It's your story to tell.
Exactly. Thank you. Um, let's see. Would I have to go to a clinic and risk reinfection to do these tests or to get treatment?
Yeah, it's a
That's another
great
one.
question. I just got an email, as I often do, from a patient in another state, um, and she wanted to do neuropsychological testing, and she was homebound, and that presented in her mind and also in my mind, bit of a problem. The nature of a lot of the cognitive tests that are done, the nature of the tests is such that it's very hard to do them virtually, over a Zoom call, let's say, over a telehealth platform. Imagine things like Tinker Toys that you're having to move with your hands.
Yeah.
Imagine building related tasks. Often those are not, again, conducive in the context of virtual encounters. So I do think the gold standard evaluations, if that's what you want, need to be done in person. I think you can empower yourself as much as you want. You can request that neuropsychologist wears a mask. You can um, make a number of requests for accommodations, and I think it's very likely that they will indeed accommodate. Certainly, they should, but it will be difficult to do a gold standard evaluation any other way than in person.
Yeah. And that's something that, yeah, again, with it taking that long, it's something that we need to plan for and save our spoons for. Is it relatively reasonable to think that people could anticipate improvement?
I do think so. Yeah, I think so. I think there are a lot of narratives, Amanda, as you know, that have been created around long COVID, and you see a lot of these narratives on Twitter. I was on Twitter a lot, and I got so discouraged by a lot of the craziness and chaos that I discerned, at least existing on Twitter. I'm on Twitter a little less, and
Yeah.
it's been good for me, right? But the narrative too common is that no one improves from long COVID at all. Nobody gets better, and certainly there are a lot of people who don't, right, or who haven't. Maybe many of the people who are joining us here have not gotten as much better as they would like. So I'll acknowledge that. But we engage people every day in my practice in our clinic from around the world who report getting better. Now, what I think we know, and what I think I need to emphasize, is that process of getting better, it can take a lot longer than it seems like it should have to take, right? It takes a lot longer. And if you're somewhere on that journey and it feels like it's 2 steps forward, 3 steps back, if it feels like it's a glacial pace of improvement, you're in good company, because that's often what we see. But over time, the arc cognitively often is toward improvement. And this is not different in that way than what we see in other populations. Often with individuals who have mild brain injuries, which is probably the best model that we've got.
Yeah.
Over time, they get better. I think it's important to note that, as a general rule, in almost every case, not every case, as problematic as this cognitive impairment is, there's one bit of good news, and that is it generally is not a degenerative condition. So the cognitive impairment people experience may wax and wane. It may fluctuate from good to bad, from bad to good, but typically we don't see a clinical picture which is a consistent erosion and a downward trend over time. We just don't see it.
That's good. That's really good to hear. I thought this
Yeah.
was a very thoughtful question. How is improvement generally journaled or documented? Do you have a particular recommendation for how patients should document this?
Yeah, that's a really good question. So, so sometimes one way we see improvement is people, we talked earlier about neuropsychological testing, right? So sometimes people have serial evaluations, meaning they're evaluated with a neuropsychologist at time point 1, at time point 2, at time point 3. And if they're evaluated at 2 time points, let's say, you can look at their score on the first exam, you can look at their score on the second exam, you can see if there's a delta, right? If there's a change, and that's going to tell you objectively whether you've improved. So doing neuropsych testing over time is one way to discern this. But I think the biggest issue here has to do not with a number, has to do not with a scale, has to do primarily with functioning. How are you functioning? Were you not managing on your job before, but now you are? Were you not understanding conversations if they were engaged in rapidly before, but now you are? Were you backing into the car in the parking lot because you weren't paying attention? You're not doing that anymore. Were you forgetting to turn off the stove, but now you are? At the end of the day, improvement's about function, right? It's not about performance on a test. That's very artificial. It's about function. And the way we can tell that people are improving, I think, is when they're functioning better.
Okay, yeah, that's great. Well, and this is a big one. What treatments exist that can help me? I do that a lot.
So I'm going to push back again gently and with
You're good.
respect
No, you're good.
against the narrative that you don't have, but that some people advocate, which is, gosh, there is no treatment for cognitive impairment after long COVID. I emphatically don't believe that. When we think about treatments, it's important to start with the idea that for many, this is a brain injury, right? Now, a traumatic brain injury involves an external blow to your head, right? There's an external blow. An acquired brain injury involves some internal process. It's not an external blow. So acquired brain injuries, ABIs, acquired brain injuries, are a very helpful, accurate model, I think, for what happens in the brains of people with long COVID. And the gold standard approach to an ABI would be cognitive rehabilitation, typically a compensatory approach to cognitive rehab, where I'm going to give you some tools, I'm going to teach you some strategies, I'm going to give you a bag of tricks, if you will, and you're going to use that to offset your deficits. In the process, you're going to function better. So the same things that someone would get if they had an acquired brain injury or a TBI, those are what long COVID patients should get. And those things, again, are various forms of cognitive rehab, typically delivered by someone called an SLP, a speech and language pathologist, sometimes by an OT, an occupational therapist, and in rare instances by a psychologist. Cognitive rehab is the first place to start. There are drug trials that are ongoing. There are some strategies that have been proven to be helpful anecdotally, at least. They need to be studied more rigorously. There was a case study published a year or so ago about using guanfacine plus NAC in the treatment of brain fog and cognitive impairment in long COVID survivors. It was interesting. It was kind of compelling. It was a very small study, needs to be replicated. That would be one example. So some pharmacologic strategies, not necessarily that harmful. Whether they're helpful is an open question, but probably worth considering. Some cognitive rehab, and then some things that we call neuroplasticity-based approaches to cognitive improvement. And those would be things like video games, brain training games that propose to fundamentally improve your cognitive abilities, and that in some other populations have been shown to be effective.
Yeah, I think we actually had someone specifically ask about that, about video games and virtual reality. Do you have any more information on that, or?
Yeah, let's talk about that.
Yeah,
I'm not as familiar with virtual reality, but for cognitive impairment, but I'm very familiar with video games, and we have conducted many studies looking at that exact thing. I'm not a paid spokesman for any company, just to be clear. I don't have any conflicts of interest, but there are two things that I particularly like, three actually, that I particularly like that I think are worth exploring. One of those is a program and a platform called Brain HQ. Inexpensive. You can buy a membership. I want to say it's $45 a year or so. Brain HQ is a series of brain games. Long before COVID, the evidence was increasingly positive that playing Brain HQ's menu of games could potentially enhance attention and processing speed in particular. So that's one, Brain HQ. Secondly, there's a company called Achille they have a video game. It's much more gamey than Brain HQ's program. It's very video gamey. They have a video game that you play on an iPad. You move the iPad around, and that is called Endeavor RX. And you get a prescription from your doctor. That prescription is in the form of an app, and that app provides you access to this video game, which again is believed to help improve attention, executive functioning, processing speed in particular. I think it's worth a try. It's not covered by insurance. They do have a program now called Endeavor OTC, Endeavor over the counter, so you don't need a script for that. I think it's promising. I think it's potentially helpful. There's another very different approach to cognitive training, brain training, that we quite like. The company is called ABI Wellness, Acquired Brain Injury Wellness. They're out of British Columbia. You could look them up. Those are the three players in the space, if you will, that I think probably offer the most promise. And if you're motivated and you want to exercise your brain in light of some evidence, at least, that it benefits, I think going down one of those roads is very much worth a try.
Awesome, thank you. Yeah, I'm glad that came up. Let's just hit the meat of the matter here. I get questions all the time about low-dose naltrexone and ADD meds. What are your thoughts?
I don't really have an opinion about low-dose naltrexone. I don't really know enough to speak definitively about that. With regard to ADD meds, we see them prescribed a lot, and obviously this is between a patient and their doctor. But I would say in a significant portion of cases, patients report that they are helpful. Guanfacine, as I referenced earlier, that's an ADD med, a popular one. That's a non-stimulant. There are others that patients use. Some of our patients are on Ritalin, for instance, which is kind of an older school ADD med. It stands to reason to me that if the clinical phenotype, if you will, of neuro-long COVID mimics attention deficit disorder, then it could be the case that treatments for ADD or ADHD could be helpful. I think it is in the category of things that I would say are very much worth a try.
Okay, thank you. And for everyone out there, this is not medical advice. Talk to your doctor. Thank you.
Yep.
Is there any experience with IVIG or approaches to autoimmunity in treatments?
I can't speak very thoughtfully to that either. I really can't speak very thoughtfully to that.
We actually have Angela Ryerson coming next week to talk about fluvoxamine. Are there any interactions with fluvoxamine that maybe we should keep in mind going forward, especially with stimulants?
It's a good question. I also can't speak very definitively to that, and forgive me.
That's an Angela question. Let's see.
I will say in the pharmacologic realm, though, I'll make this comment. Yeah. We talked about this on one of my support groups just yesterday. Sometimes the way this works is people develop anxiety and depression due to the disruptive, derailing, adverse consequences of COVID on their lives, right? It makes sense. There's no shame. Who wouldn't, right? You lose your job, you lose your identity, you have your relationships upset, you're isolated. Of course, you will develop often depression. Of course, you will be quite worried. Again, makes sense. But often that anxiety and that depression, that PTSD, and even that OCD, often those problems contribute to deficits in cognitive functioning. There's no doubt of that. So sometimes what we see is that people who appear to be cognitively impaired are actually okay cognitively, but those cognitive problems are driven by mental health concerns. And sometimes when those mental health concerns are alleviated or improved, we see the cognitive problems greatly improve. And that's why I think for people with depression, anxiety, again, PTSD, OCD, et cetera, actively engaging those mental health concerns is really important, because if those improve, it's not just going to benefit your mental health, it's going to benefit your cognitive health as well.
Yeah, and I think that speaks also to underlying societal issues where if you're living in a tent, of course you're going to be overwhelmed and you're going to have a lot of issues. So
Yeah,
living in an apartment,
exactly. Yeah,
yeah,
exactly. And I would say this, I think, you know, I've been accused of toxic positivity a few times in a few spaces, and you know, I don't think that's fair. I'm not sure I know what it means, but I don't want to do that here. I mean, yeah, everything's not all rainbows and unicorns, and you know, very aware of that. And um, I think there are two ways to look at long COVID patients, probably more than that. And one of those, to your comment about living in a tent, one of those is that long COVID patients are very vulnerable, but another one is that many long COVID patients are incredibly resilient, right? They are incredibly sturdy and strong and resilient because they are surviving in that tent, right? They're surviving couch surfing. It's so hard, but they're surviving. And and those state of affairs that I'm describing, it's not what you want, right? We don't want people living in a tent. But I think I would say to some long COVID patients, you are stronger than you think you are. You know, you are stronger and grittier and tougher than you know. And I don't mean physical functioning. That's not the benchmark I'm talking about. But internally, I would say to long COVID patients, many of you are a hell of a lot stronger than you think you are. And I think it's important to take that to heart.
yeah, it's true. It's very true. Let's see. Sorry, I'm not. I've never cried in a town hall. Thank you.
Mm, mm.
So
Always
let's.
the first time.
Yeah,
Yeah.
always the first. Okay. Let's talk about brain fog and chronic fatigue. How are they different but similarly challenging? And yeah, just leave it
Yeah,
there.
it's really interesting. I think you know, there's a whole debate about the overlap between chronic fatigue and long COVID. And I think often that conversation generates a little more heat than light.
Yeah,
I mean, to my way of thinking, they're clearly overlapping Venn diagrams, right? There are clearly overlapping spaces. How often they're the same, I'm not sure, right? Somebody has probably studied this. I don't know the exact answer. Sometimes they're quite different, but but we clearly see um, people who have profound brain fog. Maybe this isn't the majority of people that I see, but many of the people I see with brain fog don't necessarily also suffer from disabling, debilitating chronic fatigue. So you can have one without the other. Equally, you can have profound chronic fatigue, and sometimes your mind can be completely intact, right? As
yeah,
sharp as a steel trap. So I think it's important not to collapse those into each other and treat them like they're a single entity. I think they're a little bit different. What the mechanisms are of each of those, I don't exactly know. You know, does one raise the likelihood of developing the other? I don't know. But I think it's important to know that they're not necessarily the same thing.
yeah. I agree. And this is an interesting question. Person asking about the timeline of symptoms of long COVID, specifically during the initial onset. Have you noticed any trends like heightened depression, anxiety, or other things, PTSD? Anything particularly promising to share with the wave of psychiatric symptoms?
Yeah. Um, we have seen people, I have seen people, have worked with people, um, and have observed their mental health symptoms improve dramatically when they get the treatment they need. Um, I don't want to be too triumphalistic and, you know, beat my chest, but as a profession, psychologists and psychiatrists, social workers, whatever, they're often effective at treating PTSD. There's evidence that supports how one goes about doing that. They are good at impacting positively symptoms of OCD. There's evidence that provides a framework to do that. And what I have observed is not that people don't get better with mental health long COVID, if you want to call it that. It's not that people don't get better. It is more so that many people don't ever get treatment, right? So when we connect people with treatment from a mental health standpoint, they characteristically get better. Often they get a lot better. The problem isn't the treatment. The problem is getting people access to treatment. In Nashville, where I live, and I think it's fairly representative, almost, this is not completely true, but almost any mental health doctor you would want to go to has decided to work outside of the insurance system, right? Now, why that is, there are a lot of reasons, right? A lot of explanations, but finding a really fine mental health provider who takes insurance, it's no small challenge. And the ones who don't take insurance, they're pretty expensive, right? In Nashville, 180, 200, 225, 250 an hour. In New York City, you could easily double that. In California, it's dramatically more. In Miami, right? I could go on Chicago. So I think we have to admit that there's a crisis of mental health services, both in the country and in the long COVID space. And I think we desperately have to do better. And I would really call on my mental health colleagues, if any of them are here, and I would say, you've got a moral obligation, just like I do, to bend over backwards to open the doors of your practice to people with long COVID. They desperately need it. You have something to offer. Be there for them. Find a way to move out of that sticker shock approach to charging them. Do some good and see some patients with long COVID who can't afford it. I think it's really important. There's a bad mental health crisis, and we've got to do something about it.
Yeah, we have Taylor Nichols, ER doc out at UC Davis. We actually did a town hall kind of along these lines, and how we've really changed how we access healthcare in the United States, and maybe not for the better.
Yeah.
I thought this was an interesting question. Any treatments or approaches that are clearly unsuccessful or dangerous, which folks may want to avoid? Ooh, that could be loaded.
Wow. I don't know, in the cognitive or mental health realm, I have not seen that many things suggested that I would tell you are really crazy. I just haven't seen that. There may be those. I would say in the mental health space, the most important thing is to follow what I would call empirically validated treatments. And that's not just what I would call them, that's what they're called. Exactly. So empirically validated treatments are treatments that have been shown by science to work for a particular condition. Yeah. If you have PTSD, as many people with long COVID do, you should be getting prolonged exposure therapy. You should be getting cognitive processing therapy. You should be getting written exposure therapy. Maybe you should be getting EMDR. Maybe you should get cognitive therapy. You should not be getting psychoanalytic treatment where you lay on a couch. I don't want to belittle it, right? It has a place, yeah, but not in the treatment of PTSD, right? You also should not just be sitting around with your therapist talking about the big Lions win over the Chiefs and chatting about the weather, right? That's not productive. So getting the right treatments, I think, is really important. And I think having the maturity to recognize that any treatments you're going to get are probably going to take some time. If people are offering to fix your brain, to cure your brain, you should be appropriately skeptical of them, because this is a long slog that we're in, right? This is a race, and change isn't going to happen too rapidly.
Yeah, I actually have cure as a keyword alert in the group, because if someone's coming in offering a cure, I'm very skeptical.
Exactly.
Okay, and this is something I see a lot also. MRI T2 flare changes that might be normally considered age-related, and I've seen this a lot from the very beginning, where we see diffuse small white matter opacities, but we keep getting told those are normal signs of aging. Is there an alternate or some up-and-coming approach to considering these changes as significant, especially if alongside symptoms?
Yeah, I would say this. we get a lot of patients sent for MRIs, so many. In my judgment, they clearly have cognitive problems. Very rarely do they have kind of egregious, really obvious clinical findings. And I don't think that should be interpreted as meaning that their brains are intact. I think it should be interpreted as there are limits to what an MRI does. There are limits to the idea that cognitive impairment can always be seen in the context of imaging. This is why, far more than abnormal MRIs, I'm concerned about abnormal function, right?
Yeah.
I think what we need to worry about more is abnormal function and a little less about abnormal MRIs. And I think starting with psychologists who are all about function is probably the right thing to do.
See, most organizations and governments regarding disability, they don't want to pay for anything, especially from a neurocog perspective. Are there clear-cut cases or recommendations for this when people simply cannot work but are challenged by disability denial?
Yeah. I'm going to tell my dog to stop barking really quickly, and I'm going to come back in. Is that okay?
Oh, you're totally fine. Yeah.
Bear with me just a second.
You're good.
Waffles. Amanda, apologies.
Oh,
We
no,
have
you're
two
good.
dogs, Waffles and Olive, and
love it.
Waffles is being a little bit of a bad dog. Can you repeat that
I
question?
sure can. Yeah. Most organizations and government have a hard time paying for disability, and they like to deny things, especially from a neurocog perspective. Are there clear-cut cases or recommendations for this when people simply cannot work but are challenged by disability denial?
Yeah. We do regularly see people who are denied disability in the context of cognitive problems. It happens commonly. I think it happens less often when people have neuropsychological testing data to aid them and to arm them, because usually when we have our long COVID patients do a proper neuropsychological evaluation, and I referenced that earlier in the talk, they usually have some pretty clear-cut abnormalities. They're not always severe. They're sometimes mild, but typically cognitive testing doesn't necessarily look normal. So I think to bolster your case for disability, you want to do two things. You want to have some cognitive testing done, which is relatively objective, and you want to use that to argue your case. And the way you want to use that, I think, is you want that neuropsychologist or you want your internist informed by that neuropsych data to be able to write a really compelling letter, right? That's going to make an argument that that the facts are the facts, right? The data are the data. And I think talking to your doctor and saying, and it's embarrassing, right? And people are uncomfortable, but saying, hey, I need your help. Can I count on you to be invested in this? Like, can you write me not just a letter, but a strong letter? Can you tell me what you're putting in the letter? Can I review the letter? I think it's really important. When patients ask me to write a letter for them, it's my opinion. I mean, it needs to be honest, but typically I share that letter with a patient before I send it, because I think their input is really important, right?
Yeah.
And if they have things to say that are informative, I'm going to integrate those into the letter. Having a doctor who will advocate for you here makes absolutely all of the difference.
Yeah, I agree. And there are wonderful disability attorneys and advocates out there.
There are.
Yeah, go look them up. Let's see, beyond recommendations for neurocognitive and physical therapy, what other things would you recommend? Things like exercise or experiences or hobbies, yoga, meditation, diet, anything.
Yeah, I am a big believer in exercise. I think this idea, I've been smoking some pork butts on my big green egg today, 3 of them. So it's been lovely. But, the mantra, I'm not great at smoking meat, but I'm learning, the mantra is low and slow, right? Keep it low and slow. And I do think exercise has a role, low and slow, right? Pacing, low and slow exercise. Immersion in nature, I think, is really important. You know, there's some mounting evidence that says that even if you spend 30 minutes a day, 30 minutes a week, right, for that matter, in nature, which could be as simple as on the deck in your backyard with some hummingbirds and some flowers, right? That's going to be cognitively enhancing. That's going to be beneficial. Along with that, hobbies, particularly cognitively challenging ones. That could be the New York Times crossword puzzle. That could be you trying to learn another language. That could be you doing anything you need to engage your brain. This use it or lose it phenomenon, I think, is a real one, and you need to use it. The other thing I think that is underappreciated is the role of social interaction in helping enhance cognition. Loneliness is associated with cognitive decline. Isolation is clearly associated with cognitive decline. So if you don't have friendships, if you don't have relationships, again, I know it's not this simple, but you need to be about finding them, because loneliness is not your friend, right? Loneliness is your enemy.
Start a Facebook group, y'all.
Exactly.
That's what I did. Let's see. Can you talk about neurofeedback and brain hacking as alternative therapies that might have any merit?
I think neurofeedback is interesting. There's a practitioner in Nashville who's very thoughtful, and she has told me anecdotally that some of her long COVID patients have benefited from neurofeedback. I'm not aware of any formal research per se, but anecdotally, I think people report that it helps. Cognitive rehab that I referenced earlier, that's all about brain hacks. That is brain hack after brain hack after brain hack after brain hack. And I think if you're interested in brain hacks, run, don't walk to your local speech and language pathologist, and they'll give you plenty of them.
Yeah. And let's wrap it up here. I think we've gotten through everything. What's on the horizon as potential breakthroughs showing promise in texting or prescriptions or therapeutic interventions?
Yeah, I think of all of the things that are going on, and I'm a little bit of an old-fashioned guy, I should confess, right? There are some things that are new and shiny. Yeah. These state-of-the-art video game-based approaches to cognitive training, I think they're interesting and intriguing. But if you said to me, Dr. Jackson, you know, if you can only recommend one thing for cognitive improvement, what would that be? That one thing would be cognitive rehab. Probably the thing that I love the most, the approach I love the most, is called goal management training. It addresses executive dysfunction and attention. And honestly, when those problems are impaired, often everything else is impaired. Often people's experience of memory is impaired. Often people's experience of functioning is impaired. So I love goal management training. And I love a psychotherapeutic approach that isn't cognitive per se, but that I think is reliably beneficial. And that is called acceptance and commitment therapy. And if your friends and listeners are not familiar with it, they should be. I don't want to shill very much for a book that I wrote.
I was going to ask you to bring it up. No, please do.
But I will mention it because I do think, you know, it's useful. Obviously, I believe in it. I wrote a book it came out May 9th, which was happily on my birthday. It was wonderful.
Oh, I didn't know.
And that book is called Clearing the Fog: From Surviving to Thriving with Long COVID, a Practical Guide. It's available on Amazon, published by Little Brown. And that book talks about what cognitive rehab is, who can deliver it, where you can get it, what neuroplasticity-based approaches to cognitive training are, again, how you go about getting them, what's the interface between mental health and cognitive issues, how to advocate for yourself in the context of disability, how to advocate for yourself in the context of that very first appointment, crucial appointment at your long COVID clinic. And it intersects completely, if I may, with the questions people are asking. So I would encourage you to buy the book. If you think it's helpful, friends, send me an email and let me know. Yeah. I think it probably will be.
I think I have a credit on my Audible waiting for that. So, well,
Very good.
thank you again for your time, Jim Jackson, and for all your work done at Bandy. Tell Wes I said hi, and you have a great day. Thanks for being
Will
here.
do. What a pleasure. Thank you. Keep up the good work, Amanda.
Oh, I sure will. Thanks.
Great. Bye-bye.
Bye.